Greetings to you all for a new endocrine ground round. We presented this topic to different hospitals in Iraq and forums, and I'd like to share it with you through the cyber world for a wider audience. My name is Dr. Ghassan Adnan. I'm a clinical academic from Australia. Today's topic will be subclinical thyroid disease, a pragmatic approach, and I will take you why I chose this particular title, simply because, as you would have guessed by now, there's no really hard and fast rules when it comes to subclinical thyroid disease or mild thyroid disease. In today's review, we'll discuss subclinical hypo and hyperthyroidism, and we will also go through TSH normality with literature review and case discussions. The point of this topic is to, in clinical terms, is to identify whom to treat, when to treat, and why we're offering treatment or recommending treatment to that effect. We start with this case of 60-year-old gentleman treated with hypertension and dyslipidemia. He checked his thyroid function for low level of energy and with normal, found to have normal T4 and T3 and marginally elevated or modestly elevated TSH of 6.8. Upper normal is 4.5, and that's in the Abbott assay. Clinically, he had no goiter. His antithyroid antibodies were negative. His TSH repeatedly came back above the upper limit of normal. He had normal testosterone, normal calcium, and on reviewing his system, it all came back normal. The question is to treat or not to treat. The options of treatment is, would that, if you were to offer him treatment, would that improve his cardiovascular outcome? Would it improve his cognition and mental augmentation in general? Would it improve his symptomatology or not? And would it or would it not prevent progression to overt hypothyroidism? The other option is not to treat, and please do not forget that first do no harm, or in Latin primum non nocere in the Hippocratic Oath اللي تعلمنا احنا في أساسيات الطب. Subclinical thyroid, basically the definition is referred to a disease, the presence of a disease without manifestation of the symptoms, and it could represent an early stage or evolving clinical disease. Now, a lot of these patients, they still have mild symptoms. We started to shy away from the term subclinical. We nowadays اللي حصل مع الكوشنج subclinical Cushing, we start to refer to it as mild Cushing disease. And أتصور بالمستقبل القريب we will have the same thing for subclinical hypo or hyper. لأنه مثل ما قلت كثير من المرضى الحقيقة they do have some symptoms. As we all know that the symptoms are suggestive and not specific. This is one entity where when you have to rely on the biochemistry to establish a diagnosis, you just can't rely on the symptoms. As far as the subclinical hypo, ومن الآن onward I will refer to it as mild hypo. It represents about, in this study, it showed that it represents. This is a cross-sectional study. They just checked the TSH randomly through patient records review, and it turned out to be representing 9% of the population. يعني تقريبا 1 in 10 people in the street will have marginally elevated TSH. Now, in terms of etiologies, it's either for clinical use, I like to refer to it as primary and secondary. In the primary category, when you don't have any specific cause, it's either antibody positive or negative, and this will have ramification. هذا إلى تبعات فيما يخص التأثير على العلاج. Second, because either iatrogenic or non-iatrogenic. Iatrogenic, the commonest part is lobectomy. A lot of patients who have lobectomy will end up having elevated TSH. الحقيقة هؤلاء المرضى كثير بهم ال TSH بعد within 1 year will normalize, لكن في قسم من عندهم يبقون modestly elevated. And the other common cause we see for elevated TSH is lithium, amiodarone, anticonvulsant, and pharmacological. And the first advice I would suggest is these medications should not be stopped because the TSH is mildly elevated. Some of these medications will block the synthesis of thyroid hormones. Others will promote antibodies. Either way, we should continue with these medication. It's far more important than the modest derangement in the TSH. Of note, الأميودرون على سبيل المثال, it's been associated, seizing amiodarone because of clinical overt hyperthyroidism is associated with increased mortality. But even if you were to have it, you should continue on it anyway. The other different miscellaneous causes for mild hypo is TSH1 and heterophile antibodies. These are very important and common causes. Gestational subclinical, لأنه الآن بدأنا يعني we start to relax the normal reference range for the TSH, and راح يكون عندنا محاضرة عن gestational endocrine disorders anyway in the near future inshallah. And of course the recovery phase of non-thyroidal illness, you will have marginally elevated TSH as well. The other clinical definition is gradings. We nowadays grade mild hypo into grade 1 when the TSH is between the upper normal and 10, and essentially under 10, and if under 11. When it touches 10 plus, that's where you call it grade 2. And this will have an important way on your clinical decision in relation to starting or not starting treatment. TSH من يعبر العشرة باختصار, it's an indication to start treatment for any age group at any clinical scenario. This is the first message, and I will show you through why that's the case in the next few slides. Now, let's go through the TSH and try to figure out how it was, how is the reference range established, and what's the intra and inter-individual variation, and what's their roots. In clinical arena, we do recommend or highly advise that the TSH need to be routinely measured, even in a apparently healthy individual. Just like as a clinician, we should check the liver function and the blood pressure and blood sugars and renal function, of course, and electrolytes and the cholesterol. You don't need to wait for a clinical outcome to happen to check the cholesterol, for example. It's all in primary prevention medical screening, and it is cost effective. There are two reasons why we do that. The first, well, actually more than one reason. The symptoms of the mild thyroid disease are non-specific, so you can miss out, and the patient can adapt to it. وبالتالي you might end up having more patients presenting with advanced pathology. The other point is to establish the patient reference range, and I'll explain that in a second. And of course, in mild thyroid disease, you won't be able to find it out unless you check the TSH. The other important is the TSH variation when it's measured by certain assays. For the Abbott assay reads lower than the Roche assays, both in the TSH and the T4. فمن يجيك المريض ويعني عنده فحوصات قديمة لازم تعرف ال TSH مالته كان بأي بلاتفورم مسويه. Okay, so هذه حقيقة مهمة. The TSH normal reference range that we see in our day-to-day pathology results does not take into account the age, gender, weight, diurnal variation, seasonal variation, and iodine status. And this is up to the clinician, to us, to adjust these results, take into consideration these variables. With aging, TSH tend to go up. There are some gender differences, and I will show you it in the next few slides. TSH goes up with weight goes up with increasing weight, particularly with BMI more than 30. The range to the increment in TSH related to weight is marginal, though مو فشي كبير لكنه ملحوظ. Diurnal variation is another issue, with the TSH scores the highest early in the morning. The TSH tend to go up with in cold season and drop down in warm seasons. Again, TSH drops down with iodine deficiencies. So all these variables need to be taken into account, and these, the effect of these variables on the TSH is modest ولكنه ملحوظة. فيقرأ عندك شوية فوق الحد الطبيعي أو أقل إلى آخره، لكنه الفارق يكون بسيط. And this graph shows the whole 100% confidence interval. 95% confidence interval represents the reference range. There is also the 5% confidence interval, 2.5 on each end. Now, the mild underactive thyroid falls into this 2.5% confidence interval, and some people argue that subclinical hypothyroidism can be part of normality. Some people in this 5% or 2.5% population can have TSH polymorphism, where the TSH molecule is slightly different than the rest of the population and therefore doesn't read well on the sandwich assays and tend to be higher. TSH receptor polymorphism, again, is well-known fact in some population where the T receptors do not, with TSH affinity to the receptors is lower than the rest of the population. And of course, there are other risk variable factors that can affect the TSH that possibly explain this 5% variation in the confidence interval of 5% of the population. Now, please do take note that 95% of the majority of the confidence interval range between 1 and 2.5, and therefore when we offer treatment, we prefer for someone who have hypothyroid, we aim at 1 to 2.5. That's when the most of the population falls into anyway. The other important thing as we grow older, مثل ما هذا graph depicts, the 97.5% percentile, it almost doubles at the age of 80 plus than the 30 plus. Okay, كل ما يتقدم العمر TSH level start to go shift to the right. نسبة المرضى, percentage of patient with elevated TSH are as depicted here هذه الجراي bar, light gray bar females and men, and dark gray bars. The percentage goes up as we grow older, and if you could see here in the early 50s or late 40s, it's about 10% of female will have elevated TSH. Higher TSH in older population is associated with better performance in the very old population here. Particularly, that's been associated with clinically with better performance. Now, the other issue is the diurnal variation of TSH. الصبح TSH fasting status drops. It's double that in the late afternoon. So at 5 p.m. الخمسة العصر TSH حوالي تقريبا نص 60% in comparison to 60 here and 120 in fasting status. So it drops down by 50%. لها سبب من تبدأ على المريض على thyroxine. أخذ بنظر الاعتبار رجاءً أنه you adjust the thyroxine dose according to the fasting TSH, not according to the afternoon TSH. Right? لأن حيكون عندك أقل in the afternoon, and you are subsequently more likely to cut down the dose في الوقت اللي المريض يحتاج به دوز أعلى. The other issue is فيما يخص male and female distribution. It's actually a TSH variation. In the antibody negative population, there's no difference between men and women. It's only in the antibody positive population, females TSH goes higher than men. فماكو gender variation between men and women in relation to TSH range except in the antibody positive population. Ethnic variation is another important risk factor where Afro-American or Black American scores lower TSH than white American. On average 1.4 for the white and 1.1 for the blacks. واحنا ما نعرف TSH Middle Eastern كيف يكون. Again, back to the question, to treat or not to treat, that is the question. Are we treating symptoms, metabolic syndrome, cardiovascular, cognition, or weight loss issues? And you have to bear in mind spontaneous resolution of the condition. Why we treat? Why are we hesitant to offer treatment? لأنه potential أن الحالة يعني تصير طبيعية لحالها. Spontaneous resolution. There's a question mark about the clinical benefit, and there's also potential of causing harm. 50% of mild hypos can resolve back to normal. 5% per annum will progress to avert hypothyroidism with normal, with the dropping down in T4, T3. Now, the chances of spontaneous normalization is almost 50%. في هذا paper scored 37% over 32 months. So it takes few years for it to normalize. يعني لا تستعجل بالعلاج. If you decided to observe and wait, you have to wait for 2, 3, or 4 years even. The chances for the patient to remit to normal is much less when you have antibody positive. When you have goiter, هنا إذا عندك الجويتر ال odd ratio تكون in favor of treatment لأنه unlikely to recover. Females are unlikely to recover, and these are the main issues we look at. طبعا TSH كل ما يكون أعلى, it's unlikely to come back to normal. This is a study that showed how the thyroid resolve in patient. Each bar represent a patient, and dark bars represent, with dark dots represent antibody positive, antibody negative. كل هاي المرضى اللي رجعوا طبيعيين, but there is no specific pattern. So بصراحة ما تقدر identify any early signs of recovery. You just have to keep an eye on it. There is no pattern for resolution. The other important thing, once you start treatment, you are more likely to undertreat about 10% and or overtreat. Often 20% of patients you are still going to be undertreating, and 10% you are overtreating. So about 30% of your patient, once you start thyroxine, will be either higher or lower than target range. لهالسبب starting treatment is not the final call. It's the start of a long journey with the patient. يعني تخلي في بالك إنه المتابعة تكون طويلة الأمد. Another study showed about 20% of patients on thyroxine are over replaced. كل دراسة مثل يعني meta analysis كل bar represent as a paper. وهنا أيضا between 20 and 30 of patients are being under replaced with thyroxine. So it just show you that getting the patient within target range is not an easy thing. وهناك الآن دراسات إنه المريض اللي على thyroxine كل ما TSH مالته يكون above 6 or thereabout, they will have higher chance of developing cognitive impairment, cognitive function impairment long term. So the potential benefit is who benefit from our treatment and when to offer treatment and what benefit we expect. And I can tell you now the best way to offer treatment, you don't have to rush into offering treatment. Take your time with the patient. And this in relation to mild hypo and cardiovascular disease, the more cardiovascular risk factors the patient has, the more chance this patient have mild hypothyroidism. So there is an association between mild hypo and metabolic syndrome. كل ما يكون for men and women, whenever they have more risk factors in terms of hypertension, dyslipidemia, and truncal obesity, the more likely they will have elevated TSH. And just to show you the association between these two conditions. And this elegant seminal paper by Peters et al. In 2017 showed that the impact of grading TSH, grading mild hypo on long-term outcome. So the progression to overt hypothyroidism is already strong with mild hypo, but it's much stronger with grade 2. The symptoms is stronger association with grade 2. The cardiovascular risk factors much higher with grade 2, and so forth and so on. So grade 2 has established itself in corroborated papers as a high risk for bad cardiovascular outcome. فيما يخص CCF, again, if it's grade 2, TSH above 10, you are more likely to, the risk of having CCF will doubles according to this study. So that's, and the other part of this paper I will discuss down the track. Another paper here by Rodney again showed that the risk of coronary heart disease also increases if the TSH is above 10, both events and mortality. Now, like the risk of stroke is evident here for younger population under the age of 50, even with the grade 1. حتى لو كان TSH within grade 1, the risk of stroke. Like in grade 1, the risk of ischemic heart disease is less pronounced. In this paper, the hazard ratio goes up by 3-fold, and that's very alarming. Another paper here that showed the effect of mild hypo and cardiovascular and ischemic heart disease outcome with younger. Group 1 was young population. They studied 2 groups, and group 2 was older population above 65-year-old. And in the older population, all the papers looked into the impact of hypothyroidism on cardiovascular outcome, particularly ischemic heart disease, was non-significant. In the younger population, some of the papers did show significant. All right, it's 1, 2, 3 studies. So the young population is important. David Cooper, Prof. Cooper, has put his own studies here and showed the effect of mild hypo on incidence of coronary heart disease. It's age dependent in grade 1, not grade 2. Grade 2 will definitely affect at any age group. Grade 1 is the question here. If the age is about, if older population, it will have no impact on increasing incidence of ischemic heart disease. So it's no. Younger population under 65 is yes. Above 65 is a no impact. Under 65, yes impact, and so forth. Again, 75, 65 is a no. 54, the mean age in this study, it did show an impact. And therefore, the message from this meta-analysis or systematic review often, it's to offer treatment for young population under 65 is a yes, because it does have a long-term increased risk on ischemic heart disease. Again, in the grade 1 hypothyroidism with a TSH between 4 and 10. Above 10, مثل ما قلنا مرارا وتكرارا, you should offer treatment for any age group. This is another way of putting it from David Cooper. The risk of mild hypothyroidism on cardiovascular outcome increases with younger population, and as we grow older, the risk on the cardiovascular outcome, it drops down. تقل شوي شوي إلى أن there is actually a reduction in the events in the very old population above 80-year-old. Higher TSH is associated with lower cardiovascular mortality. That's the message to take home. So older patients with mild hypo, they have low risk of developing coronary heart disease. Another study in this paper, the age population, the mean was 85-year-old, And it did show in this bar here, the cumulative mortality rate drops down in the group of patients who have high TSH, and these patients are above 85-year-old. So it's good to slow down as we grow older. In terms of cognition and mood, in the numerous study that showed no impact of positive, there's no improvement in cognition once you drop the TSH back to normal. So mild hypo has no impact on cognition and on mood. على أقل تقدير, treating mild hypo does not improve the patient depression or hypo or reduce mentation. Okay. There are numerous studies done for mild hypo and hyperthyroidism with both of them showing no impact of mini-mental study exam. فهذه حقيقة numerous papers, and we are comfortable now, we are confident that we have a good evidence to advise against offering treatment for this group of patients just to improve their cognition or their memory. Like in the improvement in symptoms is important for the young population, particularly in grade 2. وإحنا اتفقنا إنه grade 2 تحتاج علاج even if they were not symptomatic. This is another study that showed TSH goes up with coronary kidney disease, but once you offer treatment, the rate of declining in eGFR decline will be alleviated, will slow down from from almost 4 mil per minute per day per year. On average, each line represents a patient, and the drop in the eGFR on average was 4 mil per annum, 4 mil per minute per annum in the eGFR. هذا التيمبو سرعة الديكلاين قلت إلى 1 mil per minute per annum, يعني قلت 75% once you offer treatment. And therefore, perhaps it's reasonable to consider treating this group of patients even in above 65-year-old, just to attenuate the decline in the eGFR. Again, to look into what I do in general in my practice, I prefer to treat younger population who have consistently elevated TSH, perhaps between 7 and 10. I'm talking about grade 1. In the older population, antibody negative and no ischemic heart disease, I'd rather not to offer treatment unless the TSH goes above 10. مع ملاحظة إنه باليounger population, even in the younger population, I'd rather to see antibody positive. No need to rush. You can always observe and wait for long term, for 2, 3, 4, or even 5 years before you consider treatment. This is a case of a 50-year-old lady who presented with inability to lose weight. وهي مشكلة راح يشوفوها دائما. The TSH was 5.2 and antibody positive. You don't need to rush treatment. The first thing you need to do is to repeat the TSH, and we did repeat it in 6 weeks time, and it drops down to 3.3, which is normal. And therefore it's important to يعني حقيقة to have more than one determination and one reading before you يعني consider labeling the patient with the disease. Another case of 43-year-old female, she had a TSH consistently above 7, antibody positive, LDL was very elevated, 4 millimole, and we started on incremental dose of thyroxine, but she stopped her thyroxine a year later. بعدها 2 years she came to see me with the TSH was already hovering over 4.3, 4.5. Upper normal is 4. She wasn't symptomatic, and I decided not to try to treat her again. So it went into remission after 2 years. Even when you start treatment, message I want to take from this case is even when you want to start treatment, please to be prepared to revisit the point. And this lady has a thyroid nuclear scan and urinary iodine, and I put it there just to show you there are inappropriate, spurious investigation. These investigations should not have been done. But you would see these cases. You see patients come in to see you with all sort of tests that were unnecessarily. What you need to do for the mild hypo is just check the antibodies and repeat the TSH. That's all what you need to do. Another study that's of, again, 34-year-old female referred to me to losing weight, and her TSH was hovering at 6.1. She was 6 months antibody positive, she's young, TSH قريب على 7, consistently elevated, and I said I'll try treatment. Her main motivation was to lose weight. احنا نعرف انه TSH مع تقدم الوزن يصعد، ف لها سبب. I wasn't expecting her to benefit from it, but she insisted, and I offered her 6 months trial, and of course after 6 months she came back to tell me there was no improvement in weight loss as we expected, وبهالطريقة وقفنا العلاج. So routine TSH in my book is a must, because it will document the patient reference range. Now with mild hypo, 1 to treat. In grade 2 you should offer treatment. Definitely you should recommend treatment الحقيقة. In grade 1, treat the young population, particularly if they have antibody positive and other metabolic risk factors, and the TSH I prefer it to be above 7. Now the question is, would you offer a treatment for these cases? You could see often antibody positive with normal TSH, and the answer should be no. Mildly elevated TSH with very mildly, marginally elevated TSH with someone who wants to lose weight because he or she are overweight, and the answer is no. Someone who's complaining of foggy brain, reduced mentation with a TSH of 5, marginally elevated, the answer is no. So the summary and the message that I'd like to take home today is subclinical or mild thyroid hypo disease is frequent. It can progress to overt disease, or it can revert back to normal over a span of few years. There are other factors need to be taken into consideration, including the ethnicity, the age, the weight, and so forth, as mentioned. Mild underactive thyroid can be associated with increased cardiovascular risks or adverse outcomes, particularly in the younger population, and particularly if the TSH is above 10. Older patient may have increase of coronary heart disease and heart failure in particular heart failure if the TSH is above 10. A lot of older patients live with a TSH between 5 and 10, and they are absolutely healthy. And the older population, by that we mean above 65-year-old. If you were to offer treatment, I suggest you aim a TSH close to the patient pre-morbid set point, or at least to the a range that's within the 95% of the confidence interval. That is to say between 1 and 2.5. صور حاجة جدا مهمة to bear in mind. Okay, we'll move on to the other flip side of the coin, that's mild overactive thyroid. By far the commonest cause of subclinical hypothyroidism is thyroid hormone replacement therapy. Any form of autoimmunity or thyroiditis or nodules can also lead to this condition. With the fact that the thyroiditis-related subclinical diseases tend to be transient by itself. Now, there's a substantial percent of cases where they actually revert back to normal, and in this condition, Graves is more likely to revert back to normal than toxic nodules. And again, it's about 5% or thereabout percentage they will progress to overt hyperthyroidism. The chances for spontaneous remission in this paper it goes all the way to about 31-35% within 5 to 7 years. So again, it takes quite a bit of time to resolve spontaneously. The impact of thyroid overactivity pardon me, is on the general health is primarily related to or the end organ damage that we worry about is the osteoporosis on one hand, where we know that the T3 alpha receptors in the bones promote bone turnover, and when you have mild overactive thyroid, there is increased risk, there's increased bone turnover, which tend to be in this case, which become in this case unbalanced. It was well established. We do have a wealth of evidence to support the risk of increased risk of fragility fractures in women, and recently in meta-analysis recently published, and that actually showed this is the same case in men just as well. This is an old study that showed the increased risk of the odd ratio of increased risk that follows the degree of TSH drop. It goes all the way to about four folds in vertebral fractures, and a little less than that in the hip fractures and the non-spine fractures. So the risk is real, and it's not particularly subtle, as evident by this paper, which was published in 2001, and in this paper they looked at 9,700 for women. So it's a fairly good number of patients. Again, the other paper I've just mentioned in 2020 published that showed the increased risk of fracture in men for both the major osteoporotic fracture here and the vertebral fractures here as well, with increase with a drop in survival rate post fractures. The pathophysiologic effect on the cardiovascular system is primarily related to the increased heart rate and the LV mass and cardiac contractility, and of course there is increase of atrial fibrillation, particularly in the older population. The other pathophysiologic changes related to mild increase in effect in the TSH in the younger group as well, while you don't see many of AF in the younger population. So the pathogenic potential and the disease polymorphism or phenotype polymorphism is age dependent. I'll put this slide actually from one of the old papers that showed the impact of FT4 on AF, and this is obviously not an issue in the mild disease because the FT4 tend to be normal in the mild disease. However, the risk of AF within the normal reference range, which goes all the way to 20, it tends to shoot up here once the TSH reaches 17 or 18. بمعنى إنه if you were, for example, to treat someone with hypopit with thyroxine, وهذا ليس موضوعنا اليوم, ولكن just to show you why we aim for the high normal range of T4, but we don't like to go to 18. We actually like to keep it between 16 and 18. Knowing from this paper that once the T4 hits 18, in any condition, even normal, does increase the risk of atrial fibrillation, particularly in the older population. Here you could see that the percentage of AF is about 10%. 1 in 10 people, with the T4 going to between 18 and 20 will have atrial fibrillation. Again, this is another study that in the age 65 and older, the chances of incidence of AF drop down substantially once the patient is either euthyroid or hypothyroid. With the hazard ratio is about 1.85. So there is about 85% increased risk of AF once the TSH goes in the subclinical stage, and there is hardly any impact on the coronaries in the mild thyroid overactivity. Now again, the risk of CCF is increased when the TSH start to drop down below 0.1. And I have shown in this paper in the mild hypothyroid disease as well. This is a diagram that clearly showed when it just delineates the philosophy of our approach. As the TSH in the clinical hyperthyroidism, the mild hyperthyroidism, as the TSH gets closer to 0.5, which is the lower bound of the normal reference range, we prefer to observe. As the TSH drops down, we are inclined to treat, particularly as we grow older. Another diagram here that shows our approach to these two different conditions. In the light gray bar, as we are inclined not to treat in the earlier group. The light gray bar represent curve يعني يمثل subclinical hyperthyroidism. As we prefer not to treat in the younger population. As we grow older, there is increased risk of all sort of event, bones and the cardiovascular system, and therefore we incline to treat as we grow older. The opposite is exactly correct for subclinical hypothyroidism. We are more inclined to offer treatment in the younger population here because there is increased risk of cardiovascular outcome. This risk will drop down as we grow older, and therefore على عكس الhyperthyroid تماما. Therefore we are less likely to offer treatment in this age group. And to put it in this table, again, if you look at the cutoff of 0.1 and the age of cutoff of 65, we are more likely to treat. We prefer, without any symptoms or risk factors in this age group, and the younger when the TSH is suppressed, less than 0.1 that is, and we are more likely to offer to treat in the younger group if they have a TSH of less 0.1, but also they need to have other risk factors, AF, osteoporosis, CCF, or even severe symptoms. In the other, even milder form of subclinical hyperthyroid, when the TSH between 0.1 and 0.5, and you have older population, we prefer to have other risk factors to offer treatment, such as CCF, AF, and osteoporosis. And in the younger population, we prefer not to treat unless and until they have severe symptoms. With this slide, I conclude, and I hope you enjoyed the lecture as much as I did myself and found it fruitful. And we'll catch up in the next grand round. See you all there and then.